Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Take two or more medications, whereas with major depression, usually the person is on only one medication. With the treatment of depression, because this is a syndrome, we do not have a way to predict in advance which medication the patient will respond to. So sometimes it's necessary to try several medications before finding one that is effective. And we tell patients that may be the case early on in the treatment to make sure that they don't become discouraged when the first medication doesn't work, because already persons are feeling that there's already feeling at times that there's no hope that they will get better. So the improvement is normally gradual, not dramatic. So we also tell the patients that you might not feel very much difference in a few weeks, but it's important that you continue to take the medication because this medication needs time to build up in your system and to make changes in the brain chemistry. So it may take anywhere from 8 to 12 weeks to feel, to experience the full benefit of the medication. But during this 8 to 12 weeks, people are showing improvement. They may notice that their sleep is returning to normal, that their appetite is improving, that they are crying less than they were. They are feeling less pessimistic. So all of these are indications that the antidepressant is working. We often get questions from patients, will I become dependent on this medication? And my response to them is no, you will not become dependent on the medication, but this is a medication that is correcting a biochemical imbalance. So if you stop taking it, you may experience relapse, just as you experience if you're diabetic and you stop taking insulin. Your blood sugar is going to increase. That doesn't mean you're dependent on it. It's just that that the insulin is necessary to control your blood sugar. You're not going to go through withdrawals. Also, patients sometimes want to know after after they return to their normal functioning level, how long how long should they take the medication? And most studies have shown that for persons with major depression, they need to continue on the medication at least 6 months and more likely 12 months after remission to prevent relapse. And once they've been in remission for 12 months, rather than abruptly discontinue the medication, we slowly taper the medication uh, to see what is the lowest effective dose that is necessary for the person to remain uh, in their usual state to prevent the depression recurrence. So all medications have side effects as well as therapeutic effects. So we have to share that information with the patient. With the SSRIs and the SNRIs, the most common side effects, headache, nausea, Sometimes persons, when they initially begin taking the medicine, they might experience difficulty sleeping, which is could be one of the uh, symptoms of the depression, feeling a jitteriness. Um, these side effects tend to uh, disappear over time. And what we often do is start persons on a lower than therapeutic dose to minimize the severity of these symptoms. The sexual problems, which for men can be loss of interest in sex, um, decreased libido, uh, delayed ejaculation, those problems, and the loss of interest in sex can also be a side effect in women. Those problems tend to be more persistent than the other four. And oftentimes those problems develop, we have to use other medications for treatment of the side effect, or we might even have to change the medication at all. The monoamine oxidase inhibitors, the dietary restrictions. If you eat certain foods, it causes a severe increase in blood pressure, which can lead to stroke, what we call a hypertensive crisis. So many people have difficulty adhering to the diet, so we're not using the monoamine oxidase inhibitors that often, but they are effective. The tricyclic antidepressants, anticholinergic side effects, which include dry mouth, constipation, blurred vision, and in some people, it can even cause confusion. Another disadvantage of using the tricyclic antidepressants is that in overdose, they have a high rate of lethality, whereas that is not the case with the SSRIs or the NSRIs. With regards to psychotherapies, um, cognitive behavioral therapy is one of the more commonly forms of therapy used for persons with depression. It helps patients to change negative thinking and behavior patterns that contribute to or result from depression. For example, a person who is depressed, if someone was supposed to meet them at 2 o'clock and they have to cancel the appointment, they may automatically think the person canceled the appointment because they had something more important to do than meet with me. Whereas the person may have canceled the appointment because they were ill, but they assume that it has something to do with them that wasn't positive. Then we have interpersonal therapy, which focuses on relieving symptoms by improving relationships with other people. Oftentimes for the major depressive disorder, which is the most serious form of depression, the treatment is a combination of medication and psychotherapy, that combination. And the same is with bipolar illness. Now, what do we tell depressed persons that they can do to help themselves along with taking medication and psychotherapy? We advise them to engage in mild exercise. We know that exercise stimulates release of dopamine, which is a neurotransmitter associated with pleasure. We also advise them to utilize any spiritual or religious supports that they have. We ask them to take tasks take large tasks and break them into small units so they don't feel that if they didn't complete everything, it was a failure. The persons who are depressed oftentimes see activities in an all or none fashion. Either I did it all or I did nothing, without able to see that they were able to complete a portion of it. We asked them to participate in activities that they enjoy. Now, there's something that we tell them not to do, and that's not to make important decisions when they're depressed, such as changing jobs, terminating relationships, and that they should wait until their mood state has returned to what is normal for them, so they won't have regret from making those decisions. So how can you help a person that you suspect is depressed? Because the person may lack energy or feel hopeless about their situation, it may be necessary for you to call the doctor to schedule an appointment for the person. Once the person is in treatment, it may be necessary for you to continue to help by encouraging the person to remain in treatment, especially in light of the fact that treatment which treatment effects may be 8 to 12 weeks before they see the full benefit of. And it's important not to ignore remarks about suicide. Persons who are depressed do commit suicide. In fact, among the ages of 16 to 24, the suicide rate, especially among Black youth, has increased dramatically over the last 10 years or so. So it's not just something that happened to adults, but also to teenagers and young adults. So in conclusion, depression is a real illness, just like hypertension, diabetes, and heart disease. Effective treatments are available, and with treatment, most people get better. Thank you for your time and attention, and I'm willing to take any questions that you might have.
Yep, I have a question about the success rate. It's higher for depressed patients over age 65, where the success rate is 25%, and younger, it's only 5% or 1 out of 20.
Mhm.
The patients that are over 65, the ones that are suicidal, do
Mhm.
they have a history of prior suicidal attempts when they're younger? Does that contribute to the higher success rate when they're older because they've tried it before when they were younger and they get better at it?
Well, the best predictor of a future suicide attempt is a past suicide attempt. Uh, Now, some persons who make multiple attempts, they may learn, you know, that this didn't work. So that's why it is important that we try to identify one, whether or not the person is receiving the appropriate treatment. That's both medication as well as psychotherapy, if there are sufficient family supports in place. We also have to look at if they're using substances, We know that persons who are using alcohol and other drugs are at a higher risk for suicide than persons who are not using those substances, because the substances affect their ability to think clearly.
I have a question, doctor. This is Chaplain Thorpe.
Yes.
You said call the doctor for the patient, for somebody who's going through depression. Okay, they get very defensive. They say, I know my health. Don't you interfere with my life and all that. Because as a chaplain, I've seen this in the hospitals. You know, I mean, they say, why this nurse or doctor and anybody has to call for me? They complain to me or my family member, and they cut them off from them, and they're very, very bitter towards them. So, and that they say, this is my life. They're not even consulted with me. So how do you deal with that kind of, situations?
Well, I would do this. I would tell them, these are the changes I've noticed. And for some people, these changes are associated with depression. I recommend that you see someone. It seems that you're in a lot of pain and you're not able to do the things that you once were able to do. And if you would like, I could call on your behalf. So I would have a discussion with them.
Yeah.
And point out the changes that you have observed, which could be attributable to depression. And you can also say, sometimes these changes are associated with medical conditions. For example, hypothyroidism can cause a clinical picture which is very similar to depression, as well as an illness known as hypoadrenalism, also known as Addison disease. So, to get a physical examination with appropriate laboratory studies to make sure that you don't have a medical condition which is responsible for this change in your mood.
Okay, thank you.
Good morning.
Good morning.
Carol Tatum. We had stated on one of our sessions that everybody experiences depression. Could you say something about that?
Okay, I think that everyone experienced the depressed mood. And depressed mood, as I said, is a response to disappointment in everyday life. So you feel sad that you didn't get a promotion or that you have an illness. But depression as an illness, if more than just feeling sad, we're talking about a sustained period. And for major depression, it's at least 2 weeks where most days or almost every day, you're feeling sad, you're experiencing problems with your sleep, your appetite, your energy level, you're indecisive, you are pessimistic about the future. You might have thoughts of suicide or hurting yourself. So that becomes depression as the illness rather than a response to everyday activity. So you're right, everybody experiences a depressed mood, just like everyone can become happy, but that's not mania. Other questions?
I had a quick question. The side effects of medication for depressed people, I've had experience with Prozac many years ago.
Mhm.
Some of the side effects may be problematic.
Correct.
You
You're
know,
absolutely right.
sleep changes,
Mhm.
lack of interest in everyday activities. You mentioned that when medication changes, it may take a long time for those effects to be noticed. Can you talk a little bit more about that?
Okay. You're absolutely right that for most people to experience the full benefit of the medication, they have to be on the maximum recommended or the maximum tolerated dose for 8 to 12 weeks. So what we're doing during that period, as we're tapering up the medication, we are seeing if there's changes in the targeted symptoms of the depression, the sleep, the appetite, the energy level, whether they're able to fulfill their responsibilities. So there may be incremental improvement along the way before they fully recover. Sometimes what we will do to monitor the improvement to complement the clinical examination, we'll use rating scales to ask patients over the past 14 days, how has your sleep been? Are you sleeping more or less than normal? So we are seeing improvement that the person may not be aware of or taken into account to show that they are responding to the medication. As I said earlier, we have medications that have side effects. All medications have side effects. So we try to select medications whose side effect can be a benefit to the patient. For example, some of the medications can cause an increased appetite. So if you have a person who has lost their appetite because of depression, then we will select that medication. If they have no other, if they have no contraindications to it, if they have a medication, if their symptom is feeling tired, we'll select a medication that tends to be energizing. So we try to use the side effect therapeutically for the patient.
I
But
had a question about the magnetic treatment. You know,
yes,
you hear on the radio.
yes.
Can you talk about that? That seems to me to be kind of futuristic or fantastic. Does that work?
It works. And the transcranial magnetic stimulation
Mhm.
is an FDA approved treatment. It's probably been FDA approved for about 3 years now. Unlike electroconvulsive therapy, where you are receiving electrical stimulation causing seizure activity, this one does not cause seizure activity. It does improve depression. One of the barriers to that treatment is cost. It's quite expensive, and it is not uncommon for persons to have I say a healthy copay associated with it. It's an outpatient treatment, but it is effective, and it is used as a treatment for persons who have not responded to, most of the time, 3 or more antidepressants.
Good morning, Dr. Bland. This is
Good morning.
John Tatum. I'm really enjoying your presentation. I have a couple of questions. One of them is when people are going to psychotherapy for an extended period of time,
Mhm.
where does the decision come from when uh, it's time to stop? I'm thinking that it's a joint decision between you and the patient, but how does that work?
How does that work? Uh, Oftentimes, um, well, I put it this way. I agree with you that it should be a joint decision. So what are the parameters for deciding now is the time to stop? If the person has been stable for, in terms of symptomatology for at least a year, and they have obtained from the treatment what they initially sought to address. They've gotten an answer, and they've gotten coping tools that they believe they can manage on their own. That would be the ideal arrangement, the ideal way to arrive at the decision to stop therapy. I don't think anyone wants to be in therapy indefinitely. Now, does therapy mean that you've solved every problem? No, but you have given persons tools that they're able to negotiate new problems that arise.
Rest. Oh, sorry.
And my second question was about stigma.
Stigma.
Yeah, there is a stigma associated with seeing a psychologist or psychiatrist.
Mhm.
How do you, what do you tell patients and non-patients about that?
Well, I try to put depression in the same light as diabetes, hypertension, arthritis. These are illnesses, but this is an illness of the brain. We have scientific evidence to show that um, there is something amiss with the brain. We have treatments available, and most people respond to the treatment. So that's what I try to do to destigmatize the illness. But you're right, that applies to other psychiatric illnesses as well, including substance use disorder. There's a stigma. People feel that alcoholism is not an illness, it's a problem with will. But we know that's not the case either. Are we successful? Not all the time, but I think we're making improvement in destigmatizing.
I have a question about the success rate of treating people suffering from major depression. What's
Mhm.
the success rate where no further treatment is needed?
Uh, for a person suffering from major depression, uh, the treatment rate improvement is about 70% of persons show reduction in symptoms. And of those persons who show reduction, about 50% receive full remission. One of the major challenges is that most people with depression aren't being treated. So the importance of public education, cannot be overemphasized.
I have a
Doctor,
question.
I have a
We stated earlier that everyone experiences depression. How do you know you're depressed? And what makes you go forward to seek help for depression? And in doing that, in talking to an individual, I guess to say, if you think you're depressed and you don't reach out for help, and is there a period of time that it progresses to something more severe? If you're not reaching out, is it something that, in other words, I guess you have to identify that trait that's caused you to be depressed, but how do you do that on your own? There is a stigma. You don't want to go forward. Sometimes it's even embarrassing. When someone reaches out to you as a professional, what are the things that you look for to help identify, yes, I think you are depressed, and I think what's causing this depression is, how do you treat them?
Okay. Well, there are self-administered depression screening skills that persons can use. They're online, and I'm thinking one called the PHQ-9 that persons can do this screening. And what the screening does is identify persons who are at risk for the illness. So the person completes the PHQ-9 and says they score in a range that suggestive that they might be depressed. And then they say, I want to get this checked out. There are things I've noticed about myself that are different. That things I've noticed that are different. And it's affecting me in a way that I don't like it.
Okay.
Doctor, I have a question for you. This Chaplain Thorpe again. One of my very good friends, she's a engineer, and she's in her 70s. 20 years ago, she was diagnosed with bipolar depression.
Bipolar
and she said
depression.
right, and her doctor says, to her, she has to get this counseling that you're talking about with some kind of a social something, the psychiatrist office, and they charge every time you go there. She charges $50. So she did that for 1 year, and she didn't find it anything helpful at all. And the psychiatrist just gives her the prescription for medicine, doesn't tell her anything about her disease or anything. And that's all, every 3 months. And she says, it's all about money. He's not telling me anything. She has to ask him, so how am I doing in my depression? Am I doing any better? Then he'll answer. And it's all done in 5 minutes, And she said, all he does is, while she's talking to him, writing the drug prescriptions. And she just fed up. So every 3 months you have to get your medicines, and the psychiatrist doesn't tell you anything about your progress or how you're doing or anything, she said.
Okay. The treatment arrangement that you described is what is referred to as split therapy, whereas a social worker or psychologist is providing the psychotherapy, and the psychiatrist is providing medication management. In the medication management, it should include some assessment of how the person is functioning while on the medication. What improvements have occurred, if there are significant side effects, if there are side effects from the medication, and to get a sense of how the person is doing on the medication in general. I think that when that type of therapy arrangement is in place, there should be a discussion to let the patient know what exactly it will,
That ain't happy.
you will be.
That is happy as a smile on the face. That ain't happy. I know what happy looks like.
what
put
the
him on mute,
psychiatrist will be doing
Tatum.
and what the therapist will be doing, so there's not a feeling of disappointment when something isn't happening. So what I would call managing expectations.
Guess we have time for one more question.
I just want to respond to Maya. Did her friend ever think about, and we've learned on this session, if you're not satisfied with your physician or psychiatrist, try another one, get a second opinion of one that you're satisfied with. I thought that's the answer you probably would have said. You know, sometimes when you're not satisfied, you're not getting the treatment or the results.
Yeah.
There are more than one, right?
Yeah.
Then get another one.
You're absolutely right.
That's right.
Well, it seems as though there are no more questions.
I really
That would
want
put it,
to,
well, make it quick because he has to leave at 10.
I just want to know where he said something about you can find that assessment online.
Yes.
I wanted to know where.
You can just Google PHQ 9.
Okay. Okay. Thank you.
And another general term is would be self-administered depression rating scales. And remember that a rating scale identifies persons at risk for the illness. It doesn't make the diagnosis.
Mm-hmm. Okay. Thank you.
You're welcome.
I'd like to thank you, Dr. Bland. I know you have a tight timetable, and this has been an extremely helpful discussion. This is probably one of the largest audiences we've had, as a matter of fact. And so it's timely that this important mental illness is discussed. And I thank you very much. And I can't tell you how much we appreciate you joining us for this hour.
Okay, well, thank you for inviting me, and I hope you found the hours well spent. Thank you.
Okay.
Yes, it was. Thank you for coming.
You're welcome. Thank you.
Very good presentation.
Thank you.
We may have time for one or two list presentations. It's 10 o'clock now, so we may have a couple of, John Buchanan, if you want, we can go through a couple of our reading list presentations. Well, we're on the mental illness theme, and this is interesting to talk about why dementia could triple if we don't change our behaviors. And of course, to say that to have a staggering number like that, living with depression is pretty frightening. And so it does become important to decide what you can do to prevent the skyrocketing of depression. And we see the good old same findings that Dr. Bland talked about: exercise regularly, don't smoke, get your blood pressure under control, limit your alcohol intake, eat heart-healthy foods that we've been talking about forever, keep your brain active and intellectually stimulated, which we've talked about forever. Try to keep yourself from having accidents. And, you know, we've been seeing a lot more bicycle fatalities, and so that bicycle and motorcycle, this should wear helmets all the time. Also, we talked last week, I guess, about trying to reduce doing those things that keep you from having accidents. As you age, your muscles weaken, and so keeping your muscles active becomes very important. And then the last thing is that take care of your mental health. Do those things that keep you socially engaged become very important. And it's interesting that everyone nowadays is appreciating the importance of meditation and spirituality and religiosity. This is particularly important to the aging population, as we refer to those people over 65, and which is us, I guess. And so it becomes even more important as we age to do those things which allow our brain cells to grow and develop and not be diminished. Now, the problem is that as we age, we sometimes get fatter. And as we get fatter, we get more likely to have dementia. And as we have high blood sugars, the same thing happens. Smoking, of course, is well known, and we still see depictions of people who are smoking across the globe, in the United States, as well as in Europe. It's interesting that in the South, the highest rates of blood pressure, high blood pressure, diabetes, heart disease, and obesity are common. And so the most important thing to do is to try to address these issues when you're younger. But if you aren't younger, then you do it where you can. So if you do it when you're younger, you can prevent it. And if you're older, you can minimize it by addressing the healthy lifestyle practices. We call it the motto: love yourself, take care of yourself, and do those things that are good for you. And an ounce of prevention, as they are recognizing, is worth a pound of cure. And so the earlier you address these issues, the better off you are. Any other comments about this? Darryl, any comments?
Hey, what? Yeah, I co-sign 100%.
Okay. Now you like this one too. 5 foods to skip after 50. And of course, many of us recognize that boosting your intake of berries, we talked about leafy greens, will help a lot. But now going down to the foods that you need to skip, fried foods, which we're noted for, are not helping. And you can see that the dietitian says it triples the calories in foods. And this, the second, is to save your fats for dinner. Avoid them at breakfast and lunch. Go with grilled, not fried. Grilled has its own hazards, but fried's even worse. Sugary drinks. Bottles, including bottled teas, they mentioned. But it's clear that sugar is one of the most toxic products that we encountered, and it's hard for us to stop with sugar. And of course, as Darryl often mentions, the sugar and fruit should be adequate. But most of us are addicted to sugars. Be careful of those packaged foods with hidden sugars like the pasta sauces, the yogurt, granola bars, oatmeal packets, and breakfast cereals. So the word to the wise is sufficient.
Dr.
Now, those,
Callender, I have a question. What if you're exercising regularly and you are eating a responsible diet and you notice yourself slipping a little bit? What should you do?
well, you know what you should do. You should not slip.
No, I'm talking about you.
Discipline. Discipline. Yeah, is that?
Oh, no, I didn't mean that type of slip.
Oh, okay.
I'm sorry. I meant you notice that you're, I don't know how to say it, you're losing it a little bit, or your mental skills are going down a little bit. You notice that you're exercising, you're eating right, but you notice that, your memory is slipping a little bit. And so what should
Well, I
you do?
think it's good to get a mental health exam to see if you have Alzheimer's, to find out whether you're right about yeah, when you say slipping, you mean your mental health is changing for the worse.
Yes.
And I think seeing a psychiatrist or neurologist to find out if you're right about that becomes important to do. Because if you actually have a mental illness, then there may be some treatment for it. Not that we have yet a good treatment for Alzheimer's, but there are other conditions that cause dementia that can be treated.
Dr. Callender, I do have a neurologist, and I'm going to him for advice on nerves. But every once in a while, he will give me a test, ask me what day it is, who's the president, and those kinds of things. So I got those right. So
Well, a neurologist is good to see, as well as most people would go to a neurologist first. Yeah. Yes, Maya, you had a question?
Oh, you're talking to me, Dr. Callender?
Oh, no, I thought somebody had a question. Okay.
Oh, I do have a question. It may not be this, but yesterday, Dr. Callender, on the news, it was all saying that those are immunocompromised, those who had kidney transplants and all that, they were talking about getting the third boost within 2 weeks. They may approve it.
Right.
Is that good?
Yes, that's the state of the art right now. Fauci has come up with the recommendation, and it seems like everybody's on board that transplant patients are going to need a booster shot. And immunocompromised patients are going to need a booster shot. Yeah.
Praise God. Praise God. Mm.
So the high sodium instant meals are something that we need to avoid. The frozen pizzas that everybody likes is not so good. So 75% of the salt in our diet comes from processed foods, not the salt shaker. So you have to keep that in mind. And then the ultra processed snacks are also talked about, and diced vegetables and nuts, all of those things, the chips, things we love, seem to be in the group that we should avoid.
Dr. Callender, I have a question about something that I'm not supposed to eat, and periodically, once in a blue moon, which is every week. What happens about potato chips and French fries? I don't know. I know I shouldn't eat it, and every once in a while I might eat it, but then I get so drowsy and groggy. What is that a sign of besides that I shouldn't eat it?
Well, usually
chips, and what does it do when it breaks down? Does it increase your sugar, or why does it cause me to be so drowsy?
I don't know why French fries will cause you, but carbohydrates will do that. And sometimes if you take a lot of carbohydrate, you can get a reverse reaction, which you make you a little hypoglycemic. But that can happen after you take a lot of carbohydrate. With French fries, I don't know why you in particular respond that way to French fries. Is that after eating a lot of French fries or just a little bit?
Just a little bit are potato chips.
Oh, potato chips. I don't know why you respond that way to potato chips.
Okay.
Anybody else have any thoughts? Dow, you got any idea why potato chips should cause you to be drowsy?
Yeah, white potatoes are famous for raising your blood sugar level, which gives you
Oh,
any sugary drink or sugary food, you get a spike in energy that lasts for about 15, 20 minutes. After that, you get, because of the blood sugar, you feel tired for like an hour, so like the overall effect when you raise your blood sugar is that overall you're going to be tired. It causes that drowsiness. Uh, so, like red potatoes, they're not going to have as much of a glycemic effect. Sweet potatoes, fine. But, sometimes what your body is telling you is that you need some potassium, which white potatoes are great in potassium, but with the sugar load, they make you tired. Uh, so, uh, but if you want to avoid the effects of all the fat from either fried French fries or potato chips, if you feel like you need some potassium, get a baked potato.
Well, that answer makes sense. So, yeah. Well, I don't. Okay, it's interesting that plague is something that we are not used to having because of the eliminating the rats and other carriers of the plague, and so we don't know what this means. This was identified as something to be aware of, but I don't know how it's going to help us, except to know that the plague is still something that comes around. And we think it's from dogs, rats, squirrels, and other things.
Gosh.
But it doesn't help us much to know that plague is still around.
Oh my God.
Warning signs of thyroid cancer you shouldn't ignore. And there are 4 symptoms that could signal this type of highly curable cancer, which requires surgery and or radiation. Thyroid cancer is a disease that occurs in the neck and usually requires somebody to observe that you've got a lump in your neck, or you have an X-ray, or often if somebody's looking at your neck when you swallow, they can see that lump. So the issue is it's curable, especially if it's diagnosed early and treated. So if you have a lump, a swallowing in your neck, if you have difficulty swallowing, hoarseness, these are some of the signs that something's going wrong in your neck, and you should see a doctor. Have a physical examination and have an X-ray. If you have chronic cough or shortness of breath, then these are some signs and symptoms that you should see your doctor, ENT specialist, or your primary doctor. The best person would be an ENT specialist because that's the person who specializes in diseases of the head and neck. So if you have any of those symptoms, it's a good idea to see your doctor about it, especially an ENT specialist. This is an article that talks about the fact that as a consequence of COVID, people are regaining some trust in doctors, nurses, and pharmacists. We know that nurses were the most highly regarded of all, and doctors and pharmacists followed them. As a consequence of the COVID and all of the attention, the doctors and pharmacists are getting to be as trustworthy as the nurses. What do you think about that?
That's nice. That's nice.
Yeah.
Right. Dr. Callender, I was listening to the news this morning. Now they're saying Delta variant in our area is in DC mostly and Frederick County, Maryland. So what about our hospital? What do you say this about our hospitals in DC?
I'm not understanding. What did you say?
They said Delta variant is prevalent mostly in DC area and in Frederick, Maryland. So what do you think this has the consequence on our hospitals?
I'm not understanding your question.
Oh, Delta variant, they said, is mostly in DC, Washington, DC, and in Frederick County, Maryland.
What is in
So what,
DC?
Delta.
Oh,
Delta.
yeah.
Delta
Okay.
variant, yeah.
Delta
Yeah, well, we
variant.
know
Yeah,
that
yeah.
we know that is common among the unvaccinated. And so what we should do is try to get everybody vaccinated, because that's where the epidemic is coming from, those people who are unvaccinated. So we need to try to get as many people vaccinated as possible.
Yeah, but they're giving us the Delta variants, those who are not vaccinated.
No, what I'm saying is, while it occurs in people who are vaccinated and unvaccinated, the majority of cases occur in the people who are not vaccinated.
Oh, I see.
So we need to get them vaccinated because most of the variants come from people who get the infection who are not vaccinated.
Oh, I see. Thank you.
Now, this is something that we should be aware of, that when you have a COVID breakthrough infection, it may present a little differently because the Delta variant does not act the same way as the original, which started off by giving you fever and all of those other things. Whereas with the Delta variant, it may present as a nasal drip and then move promptly to the lungs and make you feel like you have a pneumonia. And so most of the traditional symptoms that are associated with COVID are not as common. You're more likely to have the congestion, the sore throat, and the rhinitis. So that many people who get the Delta variant don't realize that it is different from the traditional, and they just think they have a cold. And so if you have cold symptoms, and you have exhaustion that goes along with it, that is probably one of the most important symptoms. You start getting fatigued along with the runny nose. And now, if you're unvaccinated, that's different, because then you are more likely to have the traditional symptoms, loss of smell and the other things. Whereas with the vaccinated person, it may present a little differently.
Oh, my.
And there are studies which have demonstrated that the most effective most effective vaccine against the Delta variant is the Pfizer vaccine. And there's now a suggestion that if you only had the Johnson & Johnson, that you may need a booster of the Pfizer. Some of the studies are suggesting that for example, there's a study that demonstrates that the Pfizer is 76% effective against the Delta variant, whereas the Johnson is more like 40%. And so they're suggesting that maybe if you got the Johnson & Johnson, maybe you might need a booster. But that, all the data is not in on that. But with the Delta surge, these are things that become important. We'll have more information as we
Oh my
have
God.
more patients who have it. But anyway, these are things.
Oh, it's so scary. My God.
Yeah, well, I think as we learn more, we know more. So we just have to pay attention. So, but one of the things that is most important, as you asked that question, is to make sure that as many people get vaccinated as possible, because many of these variants come from people who have been unvaccinated who get infected.
Oh my gosh.
This
Oh,
is an article that talks about how we become what they call collateral damage, which is an interesting way of calling us, which means that since we are among the lowest who are infected, who are vaccinated, we're the ones most likely to get these Delta infections, and therefore we need to make sure that everyone that is possible can be vaccinated. You can see that Black residents in that study, only 31% were fully vaccinated. Latinos did better than us,
God.
and so that we really need to get as many Blacks vaccinated as possible. I guess that's the bottom line, as an answer to your question, to get as many African Americans vaccinated as possible. Otherwise, we will die more often than
Oh
anybody
my
else.
gosh.
Yeah.
Oh no.
And
Oh,
as you
I'm
know,
so
most of
sorry.
the hospitals are going to require that the staff be vaccinated.
Good, good. Praise
And
God.
many of the schools are going to require that the teachers be vaccinated.
Good.
There's a
Wonderful.
lot of discussion as to whether or not the students need to be vaccinated, but there's no little question that the adults need to be vaccinated. And then there's an
Wonderful.
issue about, this is a great timely article about the case against masks for children, because there's a lot of situations in which some children, and this article goes on to talk about sometimes wearing masks is a problem. Some kids, especially if they wear glasses, and some people have acne and skin problems. And so there are circumstances in which children may have difficulties in addition to psychological problems, so that the most optimal thing to do is to get the teachers vaccinated, and those children who can wear masks should wear masks as well. But this is a topic that is going to become even more discussed as we go from August to September. You teachers, any comments relative to that? Now,
Dr. Callender, in the DC public schools, they're going to have a meeting to discuss the mandates for kids to be vaccinated, those over 12, and also the teachers. So there is some pushback. Some of the teachers, don't want to get vaccinated, and some of the parents don't want their kids to be vaccinated. So that's the problem that they're going to have to deal with this coming school year. What is the learning going to be like? Is it going to be hybrid, where some kids stay home, some teachers stay home, or are they going to do both, have them stay home for some classes and be on site for other classes? But the big issue is, I believe the teachers, they're going to say, well, I don't want to teach if the kids are not vaccinated. So that's what's going on.
Well, it's clear that we as our educational system is one of the lousiest in the developed countries. And so we know that the hybrid with the homeschool, with the Zooming is not been working well for many of our students. And so it's setting us backwards. But as you mentioned, these are factors that have to be dealt with, whether we like it or not. And so it's going to be interesting to see what is the outcome of the discussions that are held between the parents and the teachers and the students. So time will tell. And interesting articles about schools who take, it's clear the universities have decided that for all the college students, they have to be vaccinated for most of the colleges in the District of Columbia and surrounding areas. Although there are exceptions to the rule, but most of the college kids will need to be vaccinated in order to go to school. But for the elementary, junior high schools and others, that's going to become an issue that the unions will come up with something, and I don't know what that's going to be. Since you're in that area, John, I guess you'll keep us advised as things go on.
Yes, I'm the president of a retirees group, and some of them are substitutes, so they're going to weigh in. Everybody's going to weigh in.
Well, it's interesting that 95% of the people over 65 are vaccinated. It's the people who are under 50 who are at issue. And it's interesting that different schools are doing different things. And so it's hard to pay attention to what one school does. They even have one school who wouldn't allow teachers to come if they were vaccinated. So you have all kinds of different positions that people take. And it's clear that I just associated with the summer camp where they had 400 children and all of them were negative. So that's nice to have a situation where you have them tested and you know what they are. So you know what you're dealing with, which is contrasted with schools where you don't know whether they're positive or negative. And I think that's one of the issues that should be factored in. Are the students all negative? Are they going to be infected by the teachers, or is it going to be vice versa? So masking in schools becomes an issue, as well as whether or not to be vaccinated in the schools. And it's clear that there are administrations who don't appreciate the importance of masking or being vaccinated. So,
You know, Dr. Callender, the other thing that weighs in is the requirement to be tested again after you've had your shots.
Right.
Some of that is going on.
Yes, that is, and as a matter of fact, it's required at Howard University that you get tested. So, but you're right, that because of the Delta variant, that has become more of an issue. And as we know, children under 12 are still not eligible to receive the vaccinations. And
I had a quick question, Dr. Callender. Is the test for COVID, does that cover all the variants that come up, or do they have to change the test?
the test is good. The test is good.
Call
So
Maya
they're able to detect
and
the
ask her to
Delta and the
unmute.
Lambda. Because the issue is as we get more and more variations on a theme, will all of them be diagnostic? So far, the answer would be yes. Although we know specifically for the Delta, the answer is yes. For the Lambda, I'm not as positive because that has not become an issue yet in the United States. Okay, now what also is interesting is how the different states and the governors have different positions on whether to wear masks, not to wear masks, whether to be vaccinated. And we've left it up to the states to make decisions, and that is something that may plague us forever. And we all know that the Zoom and computer screens is not a good way to teach. but that looms large and is frightening.
You know, Dr. Callender, the big idea for these people in Florida and Texas is that you know, they don't want the government to mandate these behaviors, masking and vaccination. They want the parents and individuals to make the decision for themselves.
That's a
But,
mistake, right?
you know, yeah, well, you know,
Yeah,
it's,
well, of course, the governors aren't too, some of the governors aren't too swift either. So
you know,
look at DeSantis and some of those people. So it's but those are our rules. So we got to follow them. And this is one of the articles that talks about Moderna and Pfizer and Delta, and that Moderna may be more effective than Pfizer against Delta. And so I think with time, we're going to be able to look at this and find out. Right now, we kind of don't have all the data yet, but it's clear that there are many breakthroughs, and the breakthroughs are still in the range of 50 to 75%. So this article suggests that the Johnson may be the least responsive and may require a booster. But we don't know that for sure, but the early tests are suggesting that. And much of and the reason we aren't as knowledgeable as we might be, we're looking at results from other countries and not so much from the results in the United States. And so we're looking at their experiences and correlating them with what we think would happen here, but we really aren't sure about it. So time is going to tell. One thing we know is that the Delta variant is causing us big problems. It's 10:30, so I think we ought to stop here. Any other questions or comments as we prepare to close?
Dr. Callender, I have a question from a friend of mine who's taking physical therapy at home. Should they have shoes on or not on the support of your feet when you're doing physical therapy at home?
Oh, should you? It depends what kind of physical therapy are they doing.
For for walking purposes, and they might feel pain in their feet or ankles or something. With shoes, give more support to that ankle or foot or even the leg muscles, or what?
Well, I think as long as you have supportive, even if you had slippers that are okay, I think whatever, because people have different issues, whether you have an ankle problem or you have podiatric problem. But if you have no podiatric problem, you should walk around with safe footwear, whatever that is, that is not going to be associated with accidents. Loose sandals are no good, but appropriate footwear that is not going to allow you to slip or fall is what is desirable. I think if you already know you have problems that require support, then you need to require support. But I think if you're going to do exercising around the house, you should have safe footwear, whatever that is for you. And as long as you have appropriate fitting footwear, I think that should be adequate. Any other comments about that? About the answer to Carol's question?
They asked me to wear tennis shoes at my physical therapy.
And that's pretty safe. Yeah.
Oh, and also, Dr. Callender, we have two guests today, two new people I see. If anybody else, I know Linda's back with us again. We have
Hi.
Hi, we have Derek Freeman and Carlos Younger, Reverend Carlos Younger from
Oh,
Guest
well, maybe
Day.
they could say, they could greet us.
Okay.
Good morning to everyone, to our facilitator, Dr. Callender. I've heard so much about you through the Tatums. So it was a pleasure to be on this morning and just listen in. I thoroughly enjoyed it, and I'm the friend who's taking physical therapy. So I thank you so much for that response as well as the whole session. Have a good day.
Well, it's great to have you. We're so thrilled. This is probably the largest attendance we've had so far. And we welcome you and hope you come back again.
Yes, thank you. I will.
Okay. Who was the other one?
Derek Freeman.
Would you introduce yourself to us, Derek?
Where did he go?
His audio is not working right now for some
Well,
reason.
anyway, let him know. We're excited and thrilled that he joined us along with Mr. Younger. And we hope he is satisfied enough to come again. We welcome him. Thanks for joining us. And it's an interesting topic we had for today. And we look forward to additional topics in the future.
And we're happy to have Maya back again.
That's right, we missed her.
Yeah.
Yes.
It's good to have her back. And also Janice. We
Janice.
missed Janice last week, so it's good
Well,
to have
last
Janice.
week, my refrigerator died. And
Is
it
it better
still
now?
did. My refrigerator died.
Is it better now?
No.
No.
They came out that day. It happened the day of the, just before the group meeting. And anyway, their process, they came out, they observed, it's dead, they ordered parts. So they come back tomorrow, hopefully, to repair.
Oh my goodness. So what do you do for your food?
Well, I had my 2 grands here, so I thought it'd be safe to have a large cooler and put food in it. The problem is you have to keep it closed. So
Yeah.
every time they went in, they'd leave it open. And then I have to replenish. So I said, go home. Go home. So I'll do it by myself. It's too much to buy food. They waste buy food. So I am without cooling. I have a small refrigerator that works, juice, but
Oh, okay. All right.
very untimely. But that was
Yeah.
happening to me last week. I'm sorry I missed it. I'm sure it was great.
Yeah, we missed you.
Janice, I had the problem with our dishwasher for 3 months. They're waiting for a part that's back ordered and doing dishes by hand. And I called them, they supposed to have the part by August the 8th. They told me in June, August the 8th, I would have this part. I called them, the part still hasn't come in because they said because of this COVID-19, parts
Right.
are hard to get.
Exactly.
And I don't know, Betty is nodding her head. I don't know, whatever breaks in your house and they waiting for a part rather than replace it.
But see, in the
I'll
old
wait till
days, when something broke, they would come back with the part.
right.
Nowadays, they order it, and it's 4 different parts. Surprisingly, some parts, I don't know about all. I have 3 packages at my door now. So I pray that they can fix it. My concern is the refrigerator is only 3 years old. And it's
Wow.
a Kenmore Elite, which I thought was good, but the repairman said Elite is the LG and the LG isn't good. So at least they can fix it.
Wow.
Yeah, they forgot the LGBTQ.
Yeah.
Now we're being recorded.
Well,
Oh, Darryl will help out on that issue.
But if you order something brand new, it still takes a long time to get there.
It takes a
That's why I
long
was shaking my head because I've
Yeah.
had that happen.
Yeah.
Pearline,
Well,
it's
the
good to
good
see
thing
you
is
again.
with the homeowners.
It's good to see you too,
thing,
Dr.
it's
Callender,
just
and
the-
all of you guys. Sorry.
And I spoke to Cheryl Jones. She's out of the hospital back home, so
Oh, that's good.
feel better. So, okay, well, see you again next week.
Carol, let me say, if you continue to wash dishes, your fingernails are always so clean.
Oh, thank you. I really appreciate that, Ben. Like I want a clean fingernail, but anyway.
Fingernails.
By the way, Carol, your choir is getting together, and what's the status of your choirs?
I don't know. there's a couple of vocalists on
No.
here, Sylvia and Bonnie, but I don't know of any churches but one or two that the choirs are actually getting back. Choirs generally are not getting back per se, but they're using a lot of praise teams. But there's some churches where they're trying to get the choirs back, but I hear like Sylvia, who's told me emphatically, she's not going back to her choir rehearsal. Right, Sylvia? I'm not blasting you out. But
TMI.
but
So anyway, at Asbury, we're going back and
your
they
choir is
started-
going back.
yeah, they started, all of the choir members will have to wear masks. They have the mask that you spoke of last time.
The
They're
singing
gonna
mask.
purchase masks and purchase masks for all of the choir members. And the first rehearsal is gonna start the third week in August.
Okay, you got a rich church because they bought the choir mask for the.
No, I didn't say, no, you jumped, you skipped to the point where they bought the masks. We did not, I did not say that. That's what you
Oh.
concluded. We have to purchase the mask.
Oh, okay. The choir members have to purchase a mask.
In other words, they may get it, but we have to pay for it.
That shows
Oh,
the love and dedication of the choir member.
Yeah, that's right.
Just like robes.
Yeah, so anyway, but we're still starting, I think the first or second Sunday in September.
so you're gonna have real rehearsal and all.
Started in the third week in August. Yeah,
You going back?
yes,
Okay.
yeah. So I'll keep you, I'll let you know how it goes.
How your
You're
choir
at-
rehearsal goes.
What church are you with?
Let you know I'm singing with those masks.
Asbury Methodist Church.
Oh, okay, Stephen Key, okay.
No, Everett.
Yeah,
Everett.
Everett Williams, yeah.
Everett Williams, right, yeah, yeah. He's the one who's in charge of all of that, so.
A lot of
We'll see
people
how-
are,
We'll see how it works. But as you mentioned, many of the choir members are not going to return until January.
a
so
lot of
there's-
choir members are scared. They're scared. A lot
That's
of people
right.
are just scared.
That's right.
Just
That's-
admit it. You scared.
Right.
There's about,
Amen.
each group will only be about 12 singers. So,
I'm
and-
not scared, Jones. I'm just being cautious. Scared.
I'm scared. I'm
scared.
scared.
yeah, okay. But anyway, on that note, we'll close. Have a nice weekend and see you again next week. Thanks for the largest attendance we've had so far.
All right. Thank you, Dr. Callender.
Bye-bye.
Thank
Okay,
you.
bye.
Bye.
Bye-bye.
Everyone stay safe.
Sylvia, I'm scared because I'm a transplant recipient and I haven't had my booster yet. So
You're just being cautious.
I'm scared.
You're scared.
Yeah.
Scared with a T.
Yeah, scared to go back because I haven't. Now, once I have my third shot, then I won't be as scared.
Okay.
Hi, Bonnie.
Hello, how are you?
Hey, hey, Bonnie.
Hey, James.
Barbara. Hey,
James
Pastor.
James is in the picture.
How are you?
Hey, James.
Sylvia's son.
He just came in from Washington.
Oh,
Oh, okay. So now we had 19 people on today.
I gotta see James. Okay. Hi, Joyce.
Hey, Joyce.
See, this is an after party.
Yeah.
Oh, let me turn the tape off. Oh, what am I thinking about? Darryl, you're going to edit all this. I don't know why you weren't able to record when I first tried to get you on.
You didn't give me permission.